Thank you, everyone, for joining us for another Learning Lunch hosted by FormatApproved.com. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Training, and I'll be your moderator today. Today's Learning Lunch will cover Stage 1 EHR Alternative, Keep Your Paper Charts. We're joined today by Jason Aquilani of DrFirst. Jason has been involved with Meaningful Use since its inception in 2011, and he has played an integral role in helping more than 1,000 providers successfully attest for Meaningful Use. Some quick notes before we begin. You can ask questions of our presenter at any time during today's session by entering them into the chat area during the presentation. In the second half of our session, we will address as many questions as time allows. If we do run out of time, answers to all submitted questions will be posted to our website and sent via email link later in the week. Also, note that all registered attendees of today's session will receive an email with links to both the slides and recorded versions of this event. So we often have guests ask us if they can get a copy of the slides, and rest assured that we'll send those out to you. All right, Jason, well, first of all, thank you for joining us today.
Sure, it's a pleasure to be here.
All right, well, let's get into it then. To begin, what are the top 3 objectives for Stage 1 that have caused the most confusion for providers?
Well, from what we've seen, the 3 that have challenged the providers the most are Core Objective 8, 15, and then the menu options 9 and 10. For Core Objective 8, I think the confusion really lies around which vitals to collect for patients. What we've seen are providers are not quite sure when they can claim an exclusion. Providers are required to record a patient's height, weight, and blood pressure, but not all providers actually take all 3 of those, or 2 of them, or even 1 of them. So I think that a lot of providers felt as though they had to do all 3, even if they didn't do any of them. You can claim an exclusion if you don't record all 3, but you cannot claim an exclusion if you only do if you don't record 1 out of 3. So, for example, if you don't record blood pressure, but you do record height and weight, you had to record blood pressure. You couldn't get by just recording height and weight. So there were a lot of issues posted to CMS, and CMS actually came back and changed the rule, which may even cause more confusion. They're allowing for an optional requirement in 2013 where providers can actually do 2 of the 3 or 1 of the 3. They don't necessarily have to be forced to do all 3. So that was one issue. For Core Objective 15, reviewing the security risk analysis, conducting or reviewing a security risk analysis was a big one that really threw providers, and from what we see, it's one that's causing a headache for auditing. This is one that didn't require a numerator and denominator. Providers simply had to conduct or review that security risk analysis. Providers, from what we saw, didn't really know how to go about approaching this. They didn't know what to do within their practice or their office to actually meet this requirement. So, they're leaning a lot on the vendors to help them out with that. And I know we do provide our providers with a template that's provided by the ONC for actually meeting this objective. But that's definitely one that's providing a lot of issues for practices. And then finally, the menu options 9 and 10, your public health menu options, where providers are asked to report immunization records to the public health agency or syndromic surveillance over to a public health agency or state registry. You have to do one of these 2. You don't have to do both. You do have to do one of the 2. The issue here is that a lot of these state registries or public health agencies aren't connected to actually receive the records electronically, and they all may have their own individual processes for receiving this data, processes that aren't very well known to practices. So providers were really unsure of actually how to send this information over to the state registries and public health agencies.
That's interesting. We certainly have heard a lot about Core Objective 15 that, some people believe that if they just plugged in a certified EHR, they had, by that, satisfied their HIPAA requirement. So interesting stuff about the confusion that's out there. Let's move on. What should providers be prepared for when entering Stage 2? We're right around the corner here. People are going to be starting on Stage 2. What do they need to do to get ready?
In my opinion, I think the biggest thing is patient engagement, because what patients do will, or a provider meeting meaningful use for Stage 2 is not only dependent upon what they do or their staff does in the office, but also what the patients do once they leave the office. There's two patient engagement objectives, patients logging into patient portal and also patients sending secure messages over to providers. Providers and practices need to be prepared to notify their patients that this type of messaging is out there, meaning secure messaging, that patients can get access to their records online. They may want to put up signage within their office notifying patients that, hey, you can get access to your record online. Maybe even put a computer out in the waiting room area in a secure location, possibly, where patients can get access. Maybe have a staff member be ready to help the patient find their record online. This is a tricky one for me, though. I think it's going to be the secure message piece, where patients need to send their providers a secure message. It's going to be kind of funny to see how providers, for lack of a better word, coax the patients into sending them messages. They're not, CMS isn't looking for a big number. The threshold is more than 5%. But still, you need patients to engage with you. And from what I've seen, and going to my son's doctor, going to my own doctor, providers don't really talk much at all about sending them secure messages or accessing their record online. So it's going to be very interesting to see how practices are preparing to meet those two patient engagement objectives. Additionally, one of the big issues that we saw for Stage 1 was data entry. A lot of practices complaining about having to enter a lot of data into the system. It's costing them time, it's costing them money. They're having to hire new staff or additional staff to enter data. Practices really need to understand what new data elements need to be entered into the EHR to possibly prepare their staff for any new data entry that's going to be required outside of what was already required for Stage 1.
So when should providers start to get ready for Stage 2?
Really think they should begin now. Obviously, especially if you started Stage 1 in 2011 or 2012, you really need to get prepared as soon as possible. I know that we have some educational webinars going on around Stage 2. The sooner you wrap your hands around it, the better off you're going to be. Even if you start Stage 1 in 2013, you really should start preparing for it now. There's a lot of consistency between Stage 1 and Stage 2. So even though you're still engaged in Stage 1, learning about what you're going to have to do for Stage 2 won't be a bad thing. It won't cause your practice to go in a different direction because they are pretty closely tied to each other. But we highly recommend that you get engaged with it now, especially as vendors are beginning to be certified for the 2014 criteria. You really don't want to wait until the last minute. or else you're going to run into the same problems that you ran into for stage 1.
So let's talk about the fact, that the incentives eventually sort of flip over into reimbursement penalties, but those don't begin until 2015. So why is everyone so concerned already?
The penalties do begin in 2015. So if you're not a meaningful use user, you will have your Medicare reimbursements penalized in 2015, but that penalty is based off of actions that users take in 2014. There's a couple of big reasons why users want to start now. First, for the Medicare providers. If you're participating in the Medicare Meaningful Use Program, there's a few ways in which you can avoid the penalty in 2015. If you started in 2011 or started in 2012, you must successfully attest for the full year of 2013, which means you have to attest between January 1st and presumably February 28th. But if you do not successfully attest for the full year of 2013, then you will be penalized in 2015. You have no way of getting out of it in 2014. So those providers in 2011 and 2012 must definitely be focused on that penalty now, because if they don't successfully attest for 2013, then they will be penalized. Any provider who started in 2013, they can avoid the penalty in one of two ways. They can either attest for a 90-day period in 2013, or they attest for a calendar quarter in 2014. Our recommendation is get it out of the way. Successfully attest for 2013 for a 90-day period so you're not under the gun in 2014. Because in order to avoid that penalty, you do have to attest by October 1st of 2014. You really want to get it over with now, because in 2014, another animal's coming, and that's ICD-10. So you really want to focus on MU now and worry about ICD-10 in 2014. Don't be worried about avoiding a penalty and also trying to implement ICD-10 all at the same time. And then finally, for those Medicare providers who don't start until 2014, you're really under the gun. You have to successfully attest by October 1st. And CMS has instituted a policy where you'll attest or participate in 2014 for Medicare program based off of a calendar quarter, which means you really have 3 chances to avoid that penalty if you're going to start in 2014. First is if you attest for the reporting period January 1st through March 31st. The second is if you attest for the reporting period April 1st through June 30th. And then the final shot is if you attest for the period of July 1st through September 30th. Not quite sure that July 1st through September 30th makes much sense, because you have to attest that same night, because you have to successfully attest by October 1st. We really don't suggest doing it in 2014 because you will be under the gun. And I think this might be covered on the next slide, but I'll talk about it now because it is a big deal. If you're participating in the Medicaid program, we've seen that people or providers that participate in Medicaid program feel as though they're immune to that penalty, and they're not. They feel like they're immune because it affects their Medicare allowables. But Medicaid providers or providers participating in a Medicaid program do also bill for Medicare. And CMS states that to avoid the penalty, you must be a meaningful use user, which means you must attest that you met those requirements. Hopefully we all know that the first year of Medicaid participation requires you to only adopt a solution, implement a solution, or upgrade to a meaningful use solution. That's your first year. Your second year, you have to perform meaningful use for 90 days. Now, if I'm a Medicaid provider and I buy in December of 2013, then I do my AIU in 2013. In 2014, I'll do my 90 days. And if I successfully attest at the end of those 90 days, by October 1st, I avoid the penalty. However, if I wait until January 1st of 2014 to do my AIU for 2014, like if I buy my system on January 1st, then I cannot start my 90-day reporting period until, at the earliest, January 1st of 2015. I've already now missed that window of opportunity to avoid the penalty. So anybody that can participate in the Medicaid program must buy in 2013, or they will be penalized because they won't be able to successfully attest until 2015. I know that's a lot of information, but there's some pretty big reasons why you want to participate.
Just for folks who may not be familiar with the term AIU, what do you mean by that?
AIU means that in order to get your first year incentive payment, you only have to show proof that you've adopted a certified EHR, meaning you purchased it, or you've implemented a certified EHR, or that you've upgraded to a certified EHR. There's no usage that's required. So AIU is adopt, implement, or upgrade to a certified EHR.
So what are some other misconceptions about the meaningful use penalty that arrives in 2015?
Yeah, and I did touch on this, unfortunately, in the last slide. The big one is that the providers participating in the Medicaid program feel as though they're immune to the penalty, and they're not. The only way that you're immune is if you don't bill for those, if you don't bill for Medicare patients. But we will see providers that participate in the Medicaid program. We will see some of them be penalized if they don't understand that they have to purchase in 2013 because they won't be able to do their 90-day reporting period until 2014. So that's the big one that we've seen out there. You know, we do get the providers who, hey, I'll worry about the penalty for 2015 I won't worry about it until we get to 2015. Well, you know, you can't wait that long because it's what you do well before 2015 that affects whether or not you're going to get penalized. So, you know, the providers can't keep a blind eye to it. You can't think that the penalty is going to be delayed either. It's going to happen. You know, providers are being penalized for not e-prescribing for the e-prescribing initiative. So we really believe that CMS is going to hold their ground and they will start penalizing providers if they don't meet these requirements. So, you know, they should be acting now.
It's interesting. I think in the beginning, so many people thought of the penalties as something that was, you know, so distant in the future, and now they're really right around the corner. So it's coming quickly.
Mm-hmm.
So are Medicare providers worried about being live in time to meet that deadline?
I don't think there's a significant number that we're talking to that are really worried about it. I think there's more a sense of you know, frustration that they're being driven to adopt an EHR because of a penalty. It's the same thing that we've seen with e-prescribing. It's almost like, hey, let's hurry up and get this done, more so than you know, thinking about the clinical benefits of the EHR itself. You know, we have no problem getting them live by that October 3rd deadline. I think that a big worry is you know, meeting the requirements to successfully attest for that time period of October 3rd through December 31st. so I think the worry among providers is, okay, I get it, I can be live by October 3rd, but when is my staff going to really start understanding how to use this system? And it really depends on the EHR. How complex is it? I know ours isn't a full EMR, so we do have an advantage here at DrFirst because it's a much shorter learning curve. But I think the concern is more around not so much being live, but will we be able to successfully use the system? Because vendors can help force the issue and quickly implement or get the providers onboarded and technically be able to use. But there is that learning curve, and the providers really need to understand what the learning curve is for that EHR before they jump into that decision. And it's just my assumption that you're seeing a lot of EHR turnover, meaning providers are jumping EHR to EHR as frequently as they are right now because maybe they jumped into that decision too rashly before making that educated choice.
And so when you're talking about the 10/1 date for 2014, are you referring to ICD-10 there, or the meaningful use deadlines?
No, that's more about meaningful use, about attesting before that October 1st date of 2014. I think that's the big concern. That is a major concern right now for providers. But they really, like I said on a couple slides ago, they really should be focused a lot more on getting implemented now in 2013, because the second bullet point, the funding. You're potentially losing out on up to $15,000 in available funds if you're going for the Medicare program if you wait past October 3rd. It's a lot of money. It's a good amount of money that can be used to help offset the cost of the EHR, to invest in technology to use at the office, training time for your staff. So that's another big reason why providers really need to be live by October 3rd.
So this is a question we see a lot here at Format Approved. How hard is it for smaller practices to choose the right EHR, and what do they need to keep in mind?
I think it's really hard. I think that for smaller practices, they don't have the resources that larger practices or enterprises do to help make that selection. A lot of the providers this office staff, they're really jammed up with trying to deal with the day-to-day operations. For them to make a decision, it's usually going to mean that they're going to have to skip a lunch, or they're going to have to stay extra time, or come in early to the office. They don't have the resources to make that right decision. I think that they may be forced into making a decision without doing the due diligence. A lot of times because of these deadlines, they either want to collect extra incentives, they want to avoid penalties. So it is difficult for them. And I had an interesting conversation with CMS about a year or so ago that they're seeing that trend of smaller practices being gobbled up by larger practices because the smaller practices will benefit from the purchasing power of the resources that would be made available to them from a larger group. So it's pretty interesting. And they're kind of flooded with material on EHRs. The third bullet point, there's thousands of certified EHRs out there for meaningful use. It's difficult for them to make that educated decision. How do you sort through all that mess? I'm sure they're constantly being bombarded by phone calls. I'm sure they're constantly being bombarded by emails. It's a tough decision for them, and they just don't have those resources to help sort through whether or not a system is a fully certified system. Is it a modular system? If it's modular, what does that mean? Can I still meet meaningful use with that. So they don't have the resources to be able to answer all of those questions. One of the things that we have seen, now addressing the fourth bullet point, is going through a modular approach to meeting meaningful use. Instead of buying a big, bulky EMR, some providers are looking into this modular approach to meaningful use, buying the best of breed. I don't have to go to a full EMR, but I do have to make sure that what I do purchase can be put together, or pieced together to be considered a bundled, complete EHR. I remember attending a conference out in Colorado a year and a half or so back, and that was a topic that came up, was that it is recommended to go that modular approach because it'll be easier for your staff to learn and work off of a system or systems that aren't as big as what a full-blown EMR is.
So when should Medicaid providers start attesting for meaningful use?
Well, they really don't have to start until 2016. But I mentioned a few slides ago that if you do bill for Medicare and you don't start, or if you don't purchase your system this year in 2013, you are susceptible to that penalty. So that's one thing. The penalty may not be big for them, so they may not be worried about it. It may be just a couple of $1,000s. May not be that big of a deal for them, so they may hold off on making that purchasing decision. But that's something that they need to take into consideration. How much is my penalty, and am I willing to sacrifice that to wait until later on, 2015 or 2016 to make that purchase? One of the big things for me is that second bullet point. I believe that more than half of the allotted meaningful use money has been drawn from the piggy bank so far. I know that there's a lot of different numbers thrown out there as saying how much money is allocated for meaningful use. I think that I've seen anywhere from $27 billion to $32 billion, and more than half of that 27 has already been paid out. And if you look at the participating numbers, roughly half of all providers are participating, and 80% of hospitals are participating. Now, sure, 80% is a big number, so 20% of hospitals let's participate, assuming that not all of them are going to participate. So that's not a scary number, but the provider number is pretty scary. Meaningful use is top-heavy, as we all know, meaning you get your bulk of your incentive money in the first couple of years. But I'm definitely concerned that if providers keep coming on board at the pace that they've been coming on board, and providers are successfully attesting at the pace that they are successfully attesting or have been successfully attesting, will that remaining 50% of the piggy bank still be there by 2021 when those Medicaid providers would receive their last meaningful use incentive payment? I don't know if the government's going to be able to put additional monies into meaningful use. I think that'll be a hard sell with the public, maybe depending on the economic condition of the country at that time. But given the fact that the American Recovery and Reinvestment Act has gotten a lot of scrutiny over the last few years, I think it's definitely going to be a hard sell to put more money in. So that's why I would encourage any provider, Medicaid or Medicare, to start participating now, because you never know what's going to happen to that money. You might even see a situation where where any remaining money is pulled out. I know that there's been some talk in the past about stopping the program or stopping to pay providers, but you never know what's going to happen. Everything that's going on in the world today, may force the issue and force government's hand in, taking money out of that piggy bank and saying, hey, enough with this. We need to use this money elsewhere.
So the answer is that they should begin as soon as they possibly can, really.
Right. Right.
So are practices struggling to meet those core and menu objectives before and then during the reporting periods?
Yeah, there definitely are. It's kind of funny. What we've seen at DrFirst is the practices who are obsessed with their numerators and denominators are the practices that struggle with it the most. The practices who purchase the product and focus on just using it as a clinical tool are the ones that you never hear from, and their numbers are 99% across the board. That's what we try to tell practices every time we train them. Focus on this clinically. Meaningful use will happen. If you're concerned about meaningful use, we're not saying you won't pass, but we're going to say you're struggling. You're going to struggle, and life's going to be miserable for you and the staff because you're constantly going to be worried about the numbers. Not that you should never check the numbers, but don't make it an obsession. But typically what we see here at DrFirst is the first week is tough, the second week is not as tough, and then the third week you're pretty much off and running. Very seldom do we find practices that are struggling after the first month of their initial reporting period. We work very, very closely with our practices, and we actually proactively monitor their status. We'd rather reach out and talk to them before we get a panicky phone call from them. So we do proactively monitor our practices, but typically what we see is within that within those first couple of weeks that they've adapted to it pretty well. But it also, it's like I mentioned in the first bullet, it really depends on what kind of available resources do they have at the practice. Do they have somebody that's a quote-unquote champion of the product? So during training session, is there somebody that really gets it, that really can work with the application and work with the staff? Because we do spend time with the practice during training, but they're only going to comprehend so much. So hopefully there's somebody at that practice that can really understand and gather that information and help the practice out during those first couple of weeks.
And do you have any tips on how they should select that champion? Is it just, a question of aptitude, or?
Yeah, I mean, typically, from what I've seen in practices, there's always somebody who either loves IT, loves technology, and that's kind of the way people are growing up these days, is with a lot of technology. So I think today you see people a lot more comfortable than you did 3 years ago or 5 years ago. And a lot of times what our trainers will do is they'll spot that one person or two people or three or however many there are that really get it, that really understand it, and we'll use them as a resource and kind of lean on them to make sure that those are the ones that really do get it and that we're working with them moving forward at the practice. Because we can't be on site with the practice throughout the reporting period, or we can't hold their hand every day of the reporting period. So it's just a matter of during the training session understanding who that person is. And typically, from what I've seen, the practices do a really good job of making sure that that person that they know loves IT or understands IT is actually on that training call.
So this is something that there's been a lot of buzz about. Can you tell us what's going on with practices being audited for meaningful use?
Yeah, this is scary. We go into every practice, and when they start meaningful use, we say you will be audited. You have to take that mindset. You will be audited. Don't take any shortcuts. Do not try to cheat the system. You will be audited. Do what we tell you to do, and we actually train our users to keep an eye on certain things, to document certain things, to save certain things. We actually train them to do that so that when they do get audited, it's as painless as possible. And we've had users audited, and it's been painless. Well, it's been painless for us because we know how to handle it. I can't say it's painless for the practice. Nobody ever wants to get audited. We can tell the practice, listen, don't worry about it. You've done everything you were supposed to do. You have documented proof that you did do everything you're supposed to do. It's just a matter of time before you get this thing cleared up. And here's why you're being audited. There's certain red flags that are going to be thrown up. For example, if you claim more than 3 exclusions during the attestation process, it's a red flag, and they're probably going to audit you. But that's of no fault to you, because those objectives you justifiably excluded from those objectives because they don't apply to you. So you did the right thing. There's nothing wrong with that. I personally, one red flag is some objectives have unlike denominators. So for example, the objective for maintaining an active med list and maintaining an active problem list should have the same denominators. Why somebody would ever attest where those 2 denominators are different or unlike, I don't know, but I think that actually should fall on the vendor's shoulders. The vendor should be working with the practice to help them understand those sort of things, because the practice, they're not going to read the 1,000-page rule book on meaningful use. That's the vendor responsibility. That's our responsibility to help the practice with that. But stuff like that, that'll be a red flag for CMS. We have all the confidence in the world that our practices will pass their audits unless they did something that we didn't know about. And that has happened. We actually had a practice attest without us knowing about it. We actually walk our practices through attestation, and we found out this practice attested. And when we actually walked them through we actually had a call to walk them through attestation and found out they attested. Of course, nobody knew anything about it, but anyway, when we were walking through and correcting what they did, we found out that they entered data that was incorrect, that would have got them audited, but we were able to fix what they were able to do. Failing an audit, nobody wants to fail an audit, but it has happened and it will happen. I haven't seen anybody being dragged through the mud yet. I think one of the reasons why we work so closely with our practices, it's a selfish reason, because if practices are going to fail audits, I can definitely assume that the vendor is going to be on the hook for that as well as they should be. And we don't want that. We don't want it to negatively affect the practice, and we don't want it to negatively affect our business as well. So that's why we really take a proactive approach in working with our practices to make sure that when you do get audited, we'll get you through it.
Well, that's interesting because, it sounds like you guys are really hands-on with your clients, but I'm sure that not all EHR vendors take such a hands-on approach. So if someone is facing an audit, it seems that the first thing they should do, or one of the first things they should do, is reach out to their vendor for support, because the vendor has to have had other practices that have been through that practice. Is that, or the process? Is that safe to say?
Yes and no. It depends on the vendor. We've actually extended our consulting service for meaningful use to practices that don't even use our system. It actually, came about because when our sales team was calling practices, we found out that we're talking to them about what we do, and we found out that some EHRs weren't helping their practices, and so we actually decided to extend our service to practices not using our product, using other products, and we've had to. It was awkward at first, where we found reporting issues within the EHR where the numbers didn't make sense. Where the practice was told by the vendor, for that core executive 15, all you have to do is have a certified EHR. Well, no, that's not the case. So at first it was a little awkward because we had to go tell the practice, listen, you have to talk to your vendor about this because that isn't what you should be doing. But we've had to deal with that a lot lately because you see that out there a lot. But I think vendors are starting to dot their I's and cross their T's. But you see some vendors helping and some vendors not helping. So it's been kind of a coin flip when it comes to that.
We've even heard the rumor, and I think it is just a rumor, I don't know that there's any confirmation of this, that some folks, it may be the case that if there's been a lot of problems with a particular EHR system, that you might get on the list to be audited just by virtue of having that system. But that may just be some concern out there among the medical community.
Well, what they've done, what CMS has done actually, is they outreach to those vendors, and they will talk to those vendors about these particular issues, and give the, hey, if you don't fix this, then we're going to have to revoke your certification status. That is being done today. I don't know if what you had mentioned is going on, but CMS is very proactively reaching out to vendors that are known to kind of want to say cheat the system, but try to take a shortcut.
That's interesting to hear. So we're into the question and answer stage of our presentation today, and we do have some time for that. We've already got some questions as well. If you're in our audience and you'd like to ask our expert questions around meaningful use, auditing, etc., I'm sure he'd be happy to answer them. But let's begin with our first question. Oh, and I'd like to just, before we get to that, remind our audience that we will be sending out written answers to these questions, and if there's a particularly technical question that our expert would like to provide a fuller answer to in writing, we can certainly do that as well. Okay, so here's the first question. A new doctor joined our practice in December 2012, but previously was in a hospital out of state prior to joining the practice. Would that physician report 90 days in 2013 or 90 days in 2014 for attestation? This will be the doctor's first year stage.
It depends on whether they're Medicaid or Medicare. If they're Medicare, they can do their 90 days this year or next year. It doesn't matter. Just as long as they successfully attest by October 1st, 2014, and it's really important to make sure the provider understands that if they wait past this year, they'll be forfeiting the opportunity to capitalize on that additional $15,000 that would be made available this year. But it really just depends on what the provider wants to do. It doesn't matter if other providers in the practice started in 2011 or 2012 or 2013 for that matter. Meaningful use is based off the provider and not the practice. So the provider could be in year one or stage one, year one, and the other providers can be in year one of stage two. It's okay to have differences amongst the different providers.
That's a great point that it's tied to the provider. Does that present difficulties then if somebody's moving into a system and let's say most of the providers are ready to move on stage two, but then one is in their first year of stage one? Do you have any advice on that?
That's actually a very interesting question. EHR vendors, all of them, including us, we're making changes to our systems for the 2014 MU criteria. Legally, that situation's fine. You know, one could be in stage 1, one could be in stage 2, but the system the EHR may make changes that will affect how certain actions are performed within the system and have them certified. My suggestion is to this individual, make sure that the EHR is keeping you updated on what changes are being put in place to meet the 2014 MU criteria, because you may find that the providers who are already participating in meaningful use will have to learn new functions for tasks that they've already been performing in the past. So it's a very, very good point, very good question.
All right, let's move on to our next question. Are providers going to have to, quote-unquote, recruit younger or tech-savvy patients to meet the patient engagement threshold?
I jokingly say you should keep some extra cash in a petty cash jar to bribe your patients to send you secure messages. I don't mean that, and I'm not telling any more providers that, but
sure.
No, you have to put messaging up. You have to talk to your patients about what's available. I think that the patient portal piece, I don't think that's going to be an issue. I think it's the secure messaging piece that's going to be an issue. I think that you can, I don't want to say easily, but it's easier to get patients to log into a portal than it is to go home, log into a secure messaging system, and send you a secure messaging email. The one piece that I would recommend to providers is don't be reactive, be proactive. Being reactive is waiting for patients to send you a secure email. Being proactive is a patient goes home. For example, a situation for myself, I recently had my appendix removed. Provider could send me a secure email saying, hey, Jason, just want to know how you're feeling. How's the medication working for you? I think that as humans, we're more likely to respond to an email than to proactively go in and create a new email and outreach to a provider, and me saying, hey, doc, I'm okay. Medications are working great. No pain. If the provider outreached to me and asked me that question through that secure email, hey, this is great. Provider wants to know how I'm doing. I'm going to respond and say everything's perfectly fine, and I've got my, I just sent him a secure email. So I don't think you need to recruit more tech-savvy patients. I just think you need to be proactive in letting patients know that this type of functionality is available.
That's great advice. Here's another question for you. How high does the penalty rise? Is there any forgiveness or exceptions?
There are exceptions. There's exceptions like new docs, if you're new to meaningful use. And my apologies, I don't know what new exactly means. Like, is there a cutoff date to when you're actually now a newly practicing provider? There's also an exception for not having high-speed internet in your area of practice. So there are some exceptions. With regards to how high the penalty gets, the penalty starts at 1%, and it'll go up to as high as 5%. Now, what CMS is going to do is the penalty will be 1% in 2015, 2% in 2016, 3% in 2017, and in 2018, CMS is, and this is what they're saying now, they're going to take a look at the number of successful providers, the number of successful attestations. If more than 75% of eligible providers successfully have attested in 2017, then they will keep the penalty at 3% in 2018. If less than 75% of eligible providers successfully attest in 2017, then they're going to increase the penalty to 4% in 2018, and then potentially up to 5% in 2019, and holding that firm, or I'm sorry, 5% in they're going to increase it to 4% in 2017, 5% in 2018, and then hold the penalty firm from there. But again, it's going to affect everybody differently. It all depends on how high your Medicare allowables are.
What's the rationale there? It's an attempt to prod people, or in terms of the 75% sort of trigger?
Yeah, I don't know, because you could have people who are participating, they're just not meeting the requirement. But then you might have people saying, I'm going to retire in 2 years. I'm not even going to participate. I really don't know. I haven't asked CMS that question, and so I don't have a good answer for it. I don't agree with it because, again, you're going to have providers who really want to meet meaningful use. They just can't because they may be in their first year of stage 1 or stage 2, and it's too hard for them. Who knows what the rationale is.
Well, here we have a question from the audience that's sort of a follow-on to that. And the question is, isn't it true that in order to be exempt from the penalties for those that do not have high-speed internet or cannot meet the measures, that they must claim a hardship exemption? What are the deadlines for that?
Yeah, that is true. I don't know the deadlines off the top of my head, but they do have to claim a hardship exemption, and they will have to do so with CMS. There's some paperwork that you need to fill out. You'll obviously have to put in your area code. And they've actually already have, I believe they have a pre-designated map already that actually shows the areas and the providers with, that actually shows the areas where there is no high-speed internet, and that providers within those areas can claim that hardship exemption.
Here's a question about EHRs and their own certification. What should a provider do if their EHR decides not to certify for stage 2?
My first suggestion is call your EHR now. It's kind of funny. The rate in which EHRs are getting certified for 2014 is significantly lower than what we saw for 2011. That's because it's challenging. There's a lot that's being asked of EHRs, and like I said, we're going through this right now. We're finishing up our development for the enhancements, and we'll be certified by the end of the year. But it's challenging. There's a lot of additional work that needs to be done. The providers must ask their EHRs now what the EHR plan is and hold them to it. When will you be certified? Get a date. Once that date hits, are they certified? Call them back up if they're not. Ask them, why aren't you certified? When are you going to get certified? Because providers need to they need to be using that certified EHR, and if they're not, they need to make a decision quickly to switch, because you just can't switch an EHR in a matter of a month and start using it. It doesn't work that way. I mean, I think everybody on this call knows that it takes time to go through the selection process and then also the implementation process, especially when you're talking about the bigger systems where it might take 6 months to implement an EHR. So my suggestion, talk to the EHR company now, get a timeline for when they will be certified, set some reminders for yourself to outreach to the EHR during the time to make sure they're holding true to those timelines. And don't be afraid to pull the plug. I know it's difficult for the practices to do this because you've done so much to implement, but you really don't want to be penalized because the EHR that you're using isn't going to meet the requirements for future stages.
Well, I think we have time for one more quick question. And this is one that we've certainly heard about here, and maybe you can comment on the issue. The question is, have you heard of Massachusetts pulling medical licenses for doctors who don't meet meaningful use. Do you think this will happen nationally?
Massachusetts, it's an interesting state when it comes to healthcare. Yeah, we've heard of it. I believe there is some documentation on it. I don't know if Ezra or Mike, if you guys have any additional comments to this, but my thought is that that can't possibly hold up. But it'd be interesting to kind of follow this. I personally don't think it'll hold up.
Well, I know that the Medical Association of Massachusetts is screaming bloody murder about it, as you would expect.
Oh yeah, of course. Yeah.
I mean, they might, say something, but if they do that, they'd be shutting down, multiple practices. I don't think they can take that risk. In reality, they might be talking a lot, but I mean, that's like saying, you won't pay the firefighters. We might say that, we're not going to give them the raise, but you always need firefighters. You always need doctors.
Right. Right.
Yeah, so I certainly don't think that's something that people need to worry about anytime in the immediate future, to say the least, but it's obviously gotten a lot of folks' attention. Well, as I said before, we are nearly out of time here, so we're going to assemble those audience questions and share those with our expert. We'll follow up with links delivered via email link later in the week. I'd like to thank you, Jason, for joining us for today's Learning Lunch. It was a very informative session.
It's been a pleasure. I appreciate you guys having me.
To learn more about DrFirst and the product that they offer and the services that they offer, please visit their website at www.drfirst.com. I'd also like to thank all of our guests today. Remember that all registered attendees of this session will receive an email with links to both the slides and recorded versions of this session. For comprehensive training in meaningful use, register for Format Approved Certified Meaningful Use Professional course. The course covers the requirements for both Stage 1 and Stage 2 of meaningful use for eligible professionals and eligible hospitals, including the Medicare and Medicaid incentive programs, along with clinical quality measures, HIPAA considerations, and more. Visit the URL on your screen. That's formatapproved.com/education/courses_cmup.html to register for this course. Visit formatapproved.com to learn more about our upcoming Learning Lunches. The Learning Lunch button will take you to our entire slate of upcoming webinars. Our next Learning Lunch will air September 4th, and will cover the subject of legacy EMR data. What are my options? Keep an eye on your email box and our homepage for other upcoming topics. And thank you again for joining us today.